Hi, I'm Ishwan Natarajan, Associate Professor in the section of Oral Maxillofacial Pathology in the School of Dental Medicine. And I'm here today to present a topic on oral and oropharyngeal cancer, focusing specifically on etiology and pathogenesis of oral and oropharyngeal cancer. Before we start our discussion, I want to go over some very important learning objectives. And when you leave, or not leave this room, but when we're done with this particular module, we want you to be comfortable with the foundational concepts of neoplasia. We want you to be able to answer the following questions. What is oral cancer? What is oropharyngeal cancer? And most importantly, we want you to be able to answer your patients and tell them if there is a difference. I'm also going to introduce you to the concept of oral precancer or epithelial dysplasia as we'll define it. And we're going to go into the details and the clinical manifestations and its management in a future lecture. We're going to discuss specifically the epidemiology as it pertains to oral and oropharyngeal cancer, the where, the who, and most importantly, the differences in the why and how that defines oral and oropharyngeal cancer as two separate entities. Before we get started with oral and oropharyngeal cancer per se, I want to remind you about the definition of the word neoplasm, because that's basically what we're talking about is a neoplastic process. It's not any new growth. A neoplasm must be defined as an abnormal mass of tissue, the growth of which exceeds and is uncoordinated, and most importantly, it persists after cessation of any potential physical stimulus. In simple words, neoplasia is a disease of progressive genetic deregulation. That is the bottom line. So how do cells become successful, quote-unquote, successful neoplasms? Well, in order for a cell to become a successful neoplasm, it has to accumulate several genetic defects. One among them, and I would direct you to the article that I've cited below, but one among the defects that cells accumulate is a sustained proliferative signaling capacity, but also the ability to evade growth suppressors, resist cell death, induce angiogenesis, enable replicative immortality. And what I'm going to do is I'm going to bring all these concepts back and show you how they tie in with the clinical manifestations of oral and oropharyngeal cancer. Needless to say, neoplasia and the acquiring of several genetic defects takes many months to years, sometimes decades. So these defects accumulate over a period of time. And they can be evaluated at several levels, at the clinical level, which we're going to spend quite a bit of time in my next lecture defining. We also can appreciate these at the tissue level, which allows us to diagnose these on biopsies. And we can appreciate the changes and the early changes at a molecular level. So let's dive in to the topic of oral and oropharyngeal cancer. When we use these terms, what we're referring to in the large bracket of diagnosis is squamous cell carcinoma. What is squamous cell carcinoma? If you were asked to define it, squamous cell carcinoma is a malignant epithelial neoplasm that arises from the overlying mucosal lining that lines the oral cavity, the oropharynx, the esophagus, and several other mucosal sites. So we're talking about oral and oropharyngeal squamous cell carcinomas, or cancers. We also need to define the boundaries, and this is extremely important as we try defining these two entities. We have to define the anatomical boundaries of the oral cavity and the oropharynx. We're going to spend a little more time defining these boundaries as we progress through this talk. The big question that we want to answer at the end of this lecture is there a difference between oral squamous cell carcinoma and oropharyngeal squamous cell carcinoma? And the answer is yes. But what is the difference? You just saw in the previous cartoon that the oral cavity and the oropharynx are right next to each other. Should we really be splitting hairs? And the answer to that is also yes. And I'm going to make a case over the next 20 minutes or so to show you how that is different. Let's start with some very basic statistics and epidemiology as presented in the National Cancer Institute's website and the SEER data. What they state is 96% of oral cancer is squamous cell carcinoma arising from the mucosal epithelium. In 2009, the National Cancer Institute projected that 35,720 men and women will be diagnosed with head and neck squamous cell carcinoma. Emphasis on head and neck squamous cell carcinoma. In 2013, the National Cancer Institute projected that 48,000 men and women would be diagnosed with head and neck squamous cell carcinoma. And the reason I emphasize head and neck squamous cell carcinoma is because the National Cancer Institute, in their compilation of data, lump oral and oropharyngeal cancer in the same number. If you were to tease out just exclusively oral cavity squamous cell carcinomas, there are just 17,000 of them, both in 2009 and the 2013 projections. So the story that tells us is that oropharyngeal squamous cell carcinomas are increasing in their incidence. But it also is important to point out that when we talk about oral squamous cell carcinoma, we are not including now the lip, and by definition we're not defining and including the oropharynx, and we're certainly not including the larynx. So let's, from the get-go, define boundaries. Again, this is data from the National Cancer Institute website, where they talk about head and neck cancer at a 5-year survival rate of 64%. But if you were to tease out the data for oral cancer, the survival rate drops from 64 to 59 at 5 years and 48% at 10 years. Also, what's really important to bear in mind as far as oral squamous cell carcinoma goes is that patients diagnosed with oral cancer are diagnosed at stage 3 or stage 4, meaning that they're diagnosed a little later on in the process. Of the 17,000 men and women diagnosed, around 7,600 men and women die every year of oral cavity squamous cell carcinoma or cancer. So let's start with a detailed discussion about the pathogenesis of oral cancer, defining the boundaries, the patient profile, and the pathogenesis. Here's a great example, not for the patient, but a great example of oral squamous cell carcinoma or oral cancer. What we see in this picture on the patient's right ventral surface of the tongue, also referred to as the undersurface of the tongue, is a large ulcerated mass that has a central area of depression, and surrounding the ulceration, you see that the texture of the tissue compared to the patient's left side is much more corrugated. It's lumpy and bumpy on the surface, and what this picture doesn't show us is how much pain this patient is in as a result of this tumor. Compare that to other tumors that can also present in the oral cavity. This is an example of a malignant salivary gland neoplasm, an ulcerated mass in the posterior superior lateral aspect of the palate. When we talk about malignancies of the oral cavity, I want to emphasize that more than 96% of oral malignancies are squamous cell carcinomas. In other words, squamous cell carcinomas account for more than 9 out of 10 oral malignancies. And that's the reason why when we use the term oral cancer, and I'll be using this term throughout the next 20 minutes or so, when we use the term oral cancer, we're referring to specifically oral squamous cell carcinoma. We're not talking about lymphomas, we're not talking about salivary gland tumors or other types of malignancies. So what do we know about oral cancer? There's a lot that we do know that will help you diagnose and create a classic patient profile. Let's start with location. Just as in real estate, location is everything. So as far as oral cancer goes, the classic oral cancer prone sites are the soft palate, the tonsillar pillars, but it's not sufficient to stop your oral exam just by depressing the tongue and looking at the back of the pharyngeal vault and the tonsillar vault. It's extremely important to examine the undersurface of the tongue, the ventral tongue, the lateral tongue, the floor of the mouth, and the only way you're going to accomplish that is by taking a piece of gauze, having your patient stick their tongue out, and moving it to the left and the right to evaluate the wet surfaces of the ventral tongue on the left and the right. Pay note that there is a little finding here on the left ventral tongue that's sort of C-shaped and annular. That is a variation of normal referred to as geographic tongue. Also, be absolutely certain to examine the floor of the mouth because, again, it is a classic oral cancer prone location. Another view of the Wharton's duct and the floor of the mouth in the anterior portion. Make sure that you dab the area off with a piece of gauze as you examine this because salivation from the Wharton's duct can prevent you from examining the anterior floor of the mouth effectively. So those are the classic oral cancer prone locations. Keep in mind that none of these areas are trauma prone locations. You really can't bite the undersurface of your tongue. You can't bite the floor of the mouth. Neither can you bite the soft palate. They're not subject to friction. So the oral cancer prone locations in some ways are the diametric opposite of what we'll discuss as trauma prone locations. So As we've gone over the epidemiology, it's clear that early diagnosis is going to be absolutely key in oral cancer, or for that matter, any disease. But it's really important to recognize that early diagnosis is possible in oral cancers because the oral cavity is accessible, it's easily and readily available for examination. So what do we see in this photograph? What we have here is, again, a classic example of a patient with an oral cancer. And the way I would describe this is on the left lateral surface and the ventral surface of the tongue is a large ulcerated mass that looks, honestly, like an erupted volcano in the center with a central area of necrosis. But what's really impressive to me as I view this photograph is the fact that towards the inferior portion of this mass, there are numerous white plaques that extend far away from where this large, impressive ulcerated mass is. So the question that you must ask yourself as you see a photograph like this is, did this happen within a few days or weeks? And what we know from our definition of neoplasia is that is not true. This probably has taken months, years, maybe decades to progress to where this is at right now. Let's take a look at another photograph at this point. Do you see it now? As you examine this photograph, you're going to start appreciating there are some very subtle changes on the left anterior floor of the mouth and the left ventral tongue as you go from Wharton's duct superiorly. It's a leathery white change that's sort of butterfly shaped, and I'm going to highlight it for you right there. I'm going to take the highlight off and take a look at it again. I would describe this as a white, leathery, non-wipeable white plaque with no areas of ulceration, no erythema, very subtle in terms of its manifestation. And this is diagnostic, or at least suggestive, of epithelial dysplasia. The only way we could call it diagnostic or diagnosis is if we obtained a biopsy, also referred to as a precancerous change in the oral cavity. This is the stage at which we really would like to get these lesions with good examination technique and paying attention to some details. So the significance of early diagnosis is the number one cause of treatment failure and death in oral squamous cell carcinoma is missed early diagnosis, missing precancerous lesions at routine visits. And that's the reason why 60% of patients present with stage 3 or stage 4 oral cancer at the time of diagnosis, because we miss these early lesions. What's also important is once patients are diagnosed, patients are often lost to follow-up, again emphasizing that we really need to have these patients followed up on a regular basis. That's the reason why 5-year survival rate hasn't changed in over 50 years and has remained at around 50%. Let's define now the classic patient profile. Who tends to get oral squamous cell carcinoma? Well, going back to the SEER data, what we really see is that oral cancer is a disease of age. Your classic patient is going to be someone who is 45 years and above. But keep in mind that there are some patients, not a lot, but some patients who can be diagnosed early. The same statistics hold true for mortality rates. We see that oral cancer is a disease of age. As patients age, there is a higher tendency for mortality in these patients. So we've established the classic patient profile, the classic locations, and reminding ourselves that oral cancer is synonymous with squamous cell carcinoma. It's a malignant neoplasm that arises from oral mucosal lining. But why does it happen? And how does it happen? And that's something that we want to spend some time on as we progress through the next 10 minutes or so. Oral cancer pathogenesis. Here's what we see on the epithelium. All epithelial cells, as we know them, whether they're cuboidal, columnar, stratified squamous epithelium, simple squamous epithelium, transitional epithelium, they all lie on a basement membrane. And when we visualize a basement membrane, I picture it as a fishnet-like structure that lays on a mattress, which I would define as the lamina propria, the submucosa, or the stromal tissue. So imagine you have a mattress, that's this peach-colored platform right there, and over it you lay down a fishnet-like structure, which is your basement membrane, looking much like a fishnet that we see over here. And if you start stacking up cells, the way we know stratified squamous epithelium is wont to do, what we see is your proliferative basal cells at the very base, And then as the basal cells progress up to the surface, they get flatter and flatter, and they produce keratin on the surface that produces an impermeable membrane or a protective barrier to the epithelium. What's really important to take away from this particular cartoon is that the only proliferative cells that we see over here are going to be in the basal and maybe one layer in the suprabasal regions. That proliferation is very tightly regulated. And anything that disrupts that regulation could potentially result in bad results. And that's what we want to focus on. So here's another depiction of normal stratified squamous epithelium. What we see here is a great example of tissue from the ventral tongue or the floor of the mouth, where we have a almost straight interface between the basal epithelial cells at the very base, that is the stratum basal. And as the cells progress up superiorly, they get flatter, they're bigger, they get filled with more cytoplasmic content, intermediate filaments of keratin, and as they approach stratum superficial, or the superficial layer, they're making a very thin keratin layer that produces an impermeable membrane. So the question you want to ask yourself is, how does and what must an epithelial cell do to become a successful cancer? And where is the epicenter? I think I've already given you the answer. The epicenter is the basal layer. Pay attention to the other name for the stratum basal, also referred to as stratum germinativum, because that's where germination takes place. That's where proliferation takes place. Anything that disrupts that regulation in the basal layers is going to go bad. But there's another way you can think of epithelial cells. I tend to be simplistic. I think of epithelial cells as cookies. So when you look at this photograph below, what do you see? Well, I see a cookie factory. But I also see this gentleman in the white hat examining all these cookies. Let's think of him as Mr. Gene. He's really responsible for making sure that these cookies are nice and round, have the right amount of chocolate chips, and baked right before they go out, right? Well, what if you take him away? What if you disrupt Mr. Gene? Then you really have a problem. Here is a diagram that I want to spend some time on. This is a very busy cookie factory. Oh, did I say cookie factory? No, I'm sorry. It's the cell cycle. And I'm sure you've revisited or visited the cell cycle before, but I want to spend some time on the cell cycle. What we see down on the slide is that I've labeled cell cycle is the cycle through which cells in the basal layers go around. They go from G1S, G2M, and at various checkpoints you have guys like Mr. Gene making sure that everything's going through in a regulated manner. Mr. Gene's making sure that there's enough flour, enough chocolate chips, enough butter, enough water, or in the cell's case, the cell's making sure that there is no DNA damage, it's making sure that there is enough nutrition available, it's making sure that there is enough quality checks to make sure that the cell can proceed to the next level or next cycle of proliferation. So the big Mr. Genes that I see over here are RB, ARF, P16, and P53, and I'm going to focus some attention on those players as we proceed. What happens in cancer and the progression to cancer is fairly early on, at least in the case of oral cancer, we have frequent evasion or suppression or deletion or abrogation of growth suppressors, Mr. Genes. In addition, we could have additional genetic defects in proliferative signaling, cell death, angiogenesis, and immortalization. When you have disruption of the entire cookie factory or the cell cycle, that's when you end up with mutant cookies, cells, you name it. There are other ways of thinking of epithelial cells. I like analogies, and I also like to think of epithelial cells as fish. And given that we compared the basal membrane to a fishnet, let's think of fish in a fishnet. So when you think about the stratified squamous epithelium, I want you to picture a movie like Finding Nemo. We have a bunch of fish filling up a fishnet. What we have here is a great example of stratified squamous epithelium derived from the classic cancer-prone locations, the ventral tongue, the floor of the mouth, the soft palate. What's typical of the epithelium in these areas is that the epithelial lamina propria interface tends to be fairly flat. So these are fish in a fishnet that's fairly flat. Compare it to epithelium in areas like the lateral tongue and the attached oral tissues, where you have the interface between the epithelium and the underlying lamina propria thrown into multiple folds, referred to as reedy pegs. And in this case, what you're seeing is fairly tapered or sharp-shaped reedy pegs that allow for a mechanical advantage and attachment. And I compare them to Velcro, where you have fingers going down and fingers going up, making sure that there is a mechanical advantage for the epithelium to stay intact. So here we're thinking of epithelial cells or fish that are non-proliferative in these reedy pegs. What happens when you fill a tapered reedy peg, or when you have a flat interface with a ton of proliferative cells or proliferative fish? Again, take a look at this fishnet. It's nice and sharp. But if you fill it up with a bunch of different things, it's going to go take on a bulbous shape as opposed to a tapered shape. That's what happens when things go awry with genetic dysregulation. Epithelial cells start proliferating, and they fill up these fishnets to the reedy pegs, and if you string them next to each other, that's what we see. We see a whole host of bulbous, rounded reedy pegs, RETEPEGS, and that's what we see when we see an example of epithelial dysplasia, which is on the right side. We see that the interface has been changed from what we see on the left, which is very flat in the normal. And on the right, with the epithelial dysplasia lesion, we're seeing that the reedy pegs are taking on a little more bulbous appearance, almost like little nipples sticking down into the underlying lamina propria. And also what's important to note is that the overlying epithelium is a lot more hyperkeratotic, meaning it has a thick layer of keratin that translates to the clinical features of a white plaque, as we'll explore the clinical features. We diagnose these changes as epithelial dysplasia when we see the following changes. What we're seeing here is the basal epithelial cells that are normally non-proliferative are undergoing proliferation abnormally, changing the morphology of the reedy pegs. You see the little undulating surface at the interface with crowding of the basal epithelial cells and hyperkeratosis on the surface. These are abnormal findings, and we can diagnose mild epithelial dysplasia when that proliferation of basal cells is restricted to the bottom 1/3 of the epithelium. Pay attention that the basement membrane is intact. In moderate epithelial dysplasia, the basal proliferation extends maybe up to half or more of the epithelium. Again, paying attention to the basement membrane or the fishnet being intact. This is precancerous change. We diagnose this as moderate intraepithelial dysplasia. When that proliferation extends all the way up to the surface, we call that severe intraepithelial dysplasia, or some people may refer to as carcinoma in situ. Again, pay attention that the basement membrane interface is intact, but the reedy pegs have been thrown into multiple large bulbous folds. What's also important to pay attention to in this particular slide is the fact that the underlying lamina propria contains several large dilated blood vessels filled with capillaries that translates to what we see clinically as a rough surface red and white plaque. So epithelial cells can undergo proliferation in an uncontrolled manner, and as long as it's restricted to within the fishnet and the fish haven't escaped the net, we call that epithelial dysplasia or precancerous change. But when these fish learn how to chew through that net or make the enzymes or gain of function mutations in matrix metalloproteases or inhibit tissue inhibitors of matrix metalloproteases, then we have a problem. And that's when we have invasion and break through the basement membrane barrier and the ability of cancerous cells to spread from one primary site to another part of the body through either the hematogenous routes or lymphatic spread. By now, these cells have enough autocrine signaling mechanisms or other signaling mechanisms that allow them to survive in a foreign environment. They're also able to avoid immune destruction. They're able to harness the power of surrounding tumor-promoting inflammation, and they're constantly undergoing change with genome instability and continued mutations. To review these concepts, I encourage you to go back to this article, Hanahan and Weinberg paper from 2011, and updates to it for foundational review on neoplastic concepts. So let's bring it back to oral squamous cell carcinoma, or squamous cell carcinoma in general. Now we have these fish that are mutated, that have learned to chew through a net. They've escaped the net, and that's what we see happening here. The epithelial cell down into the underlying connective tissue corresponds to what we see at the microscope. We have squamous cell carcinoma. We have these epithelial cells who don't care about making a layer of epithelium on the surface growing superiorly. Rather, what they're doing right now is invading through the basement membrane into the lamina propria, into the musculature, and beyond. That's what we see clinically, histologically, and at the molecular level. This bears out, this accumulation of mutations bears out in research by the Califano group in 1996 and several other groups, showing that this is not a multi-day or multi-week process, but rather a multi-year, multi-decade process where you have a sequential accumulation of mutations. As seen over here, we have mutations in 9p, mutations in 17p. 9p corresponds to the p16 locus, 17p corresponds to the p53 locus, and so on and so forth. So if we were to think about a schematic that defines the progression from normal to invasive squamous cell carcinoma, here's a great schematic to keep in mind. In the setting of underlying genetic susceptibility, and that is absolutely key, you could have cumulative genetic alterations, maturational disturbance, pre-malignant changes that we diagnose as epithelial dysplasia, and eventually squamous cell carcinoma. We could think of this as a low simmering fire. Add to this fire a carcinogenic primer or promoter, and then you have a raging fire. It's like adding fuel to a fire, making this blaze so much more out of control. A great example of a carcinogenic primer or promoter in the setting of oral squamous cell carcinoma is tobacco. So think of tobacco as a fuel that drives an underlying genetic deregulatory fire. Alcohol can certainly be considered a risk factor, and age, because we do tend to accumulate genetic mutations as we age. Coming back to tobacco, there are several ways in which tobacco can be used. The number one cause of, not cause, but risk factor associated with oral squamous cell carcinoma is cigarette smoking. Emphasizing that smoking tobacco is a risk factor are the statistics that go along with it. We know that 85% of patients who with oral cancer are smokers. The contrary is also true. 15% of non-smokers can also develop squamous cell carcinoma. So that speaks to the genetic susceptibility component of oral cancer development. What's also not surprising to note in these statistics is a 20-fold increased risk in heavy smokers. Another important point that I want to draw on this particular slide is that patients with a distant history or even a history of having quit smoking in the past, in those patients, tobacco smoking should be considered a risk factor. So bear in mind, as you take a patient's history, do not dismiss a previous history of tobacco smoking. We know that tobacco does its thing by modifying the additives that go into cigarettes. The nicotine-modifying additives release cytotoxic free radicals causing tissue damage, and much of this is thought to pool around the floor of the mouth and the ventral tongue, the lateral tongue, that corresponds to the areas that we considered cancer-prone locations for oral cancer. Alcohol can be considered a cofactor, but in some patients an independent risk factor, especially in those patients who consume a heavy amount of alcohol, with some of the proposed mechanisms listed below. As a point of interest, it should be noted that there is no association between alcohol-containing mouth rinses and oral squamous cell carcinoma. Just thought you'd like to know. Let's go back to that busy diagram that we went over as we looked at the mutant cookies and the cookie factory. Let's bring it back to epithelial cells right now. Epithelial cells in the basal layer go through cell proliferation, and they are kept in check at G1S by RB if there is excessive proliferation. I think of RB as a fire station. There are several other important players over here. Most importantly, P16, which corresponds to the 9p locus, and P53, which corresponds to the 17p locus. I want you to think of P16 and P53 as the guys that pull the alarm in order for the fire station to respond to a fire. So remember, fire station, RB, P16 and P53, the guys that pull the alarm. if you have early deletion of p53 and loss of function of p16 fairly early on, what do you think is going to happen? Cyclin D1 and CDK4/6 are going to drive transcription. RB doesn't know that there is a fire because no one's pulled the alarm. And the cells continue through proliferation and continue to progress towards epithelial dysplasia and squamous cell carcinoma, in addition to accumulating other mutations. But these are the very earliest changes that we see in squamous cell carcinoma, progression to squamous cell carcinoma. Early deletion of p53, loss of heterozygosity or allelic imbalance of p16. So I want you to keep this genetic profile in mind when we think about oral squamous cell carcinoma and epithelial dysplasia. Early allelic imbalance of 9p21 locus, which corresponds to loss of p16 expression and loss of function. Early mutation and deletion of p53. Why does this matter? Well, we're going to revisit this as we discuss the pathogenesis of other squamous cell carcinomas in the orofacial complex. So for that reason, there are several reasons why this matters. We'll stop right